Good afternoon and good morning for those of you on the West Coast, Alaska and Hawaii. You have joined us for a webinar on discharge planning guidance for APS programs. I'm Lori Delagrammaticus. I'm going to be the moderator today for this webinar. We're sorry we're starting a little bit late. We had a little bit of technical difficulty, but I think it's going to have been worth the wait. As you know, APS often has to assist clients in navigating various settings and levels of care, and that work can be complex and frustrating, particularly when APS is concerned there may be an unsafe discharge. So this webinar will discuss some of the discharge planning issues faced by APS, including how the process is supposed to work according to federal law and guidance, and some of the strategies we can use and the tools developed by APS and their community partners to seek safe and appropriate discharge plans. We have two presenters today. We have Deborah Greenfield, who began her career in New York State in 1987, first with the New York Department of Social Services and then with the Department of Health. And during that time, she was primarily responsible for certification, inspection, and enforcement of both licensed and unlicensed adult care facilities statewide. And she also worked with the licensed home care services agencies. In 2005, she moved to the New York Office of Children and Family Services Bureau of Adult Services, where she oversees the family type home for adults program in conjunction with the local social service districts. She also oversaw and provided technical assistance to a number of APS units within the local district, most recently in New York City. During that period, she was an active participant and a co-chair of the Discharge Planning Work Group. This was a wide-ranging group of state agencies, county APS providers, and associations who met regularly in an effort to increase understanding of discharge planning rules and regulations. The goal was to enhance collaboration and develop partnerships to achieve better discharge planning outcomes. Ms. Greenfield also participated in the Complex Discharge Planning Work Group, which was an outgrowth of the original work group. And in that group, hospital discharge planners present difficult cases to representatives of the larger group who then attempt to brainstorm solutions. Our other presenter today is Alan Lawitz, and since November of 2007, he has served as the director of the Bureau of Adult Services of the New York State Office of Children and Family Services. The Bureau oversees adult protective services and family-type homes for adult programs. He co-authored the New York State Cost of Financial Exploitation study that was issued in June of 2016. We all know the Under the Radar study. Alan previously was an associate attorney at the New York State Department of Health, heading up the long-term care group of the Bureau of Home Counsel and dealing with legal issues related to assisted living, home care facilities, nursing homes, and home care, among other areas. He has authored several articles in this field, including the Assisted Living Reform Act of 2004, New Models of Care, New Choices for Consumers, NYSBA Health Law Journals, that was in the winter of 2006. He's also previously served as a senior attorney for the former New York State Department of Social Services, representing the agency in the area of APS, adult care facilities, assisted living, and homeless housing, and served as a counsel to the New York State Homeless Housing and Assistance Corporation, and he graduated from Columbia University. He is also the Northeast Regional Representative for NAPSA, and he has been the recipient of the 2016 President Award for his contributions to the field of APS and NAPSA. So let's welcome both Deborah and Alan, and let's get started.
Thank you, Lori. This is Alan Lawitz, and hello, everybody. And thank you, Lori gave a very exhaustive resumes for both of us, and I thank you very much. Let's get right to it. And we talked about discharge planning. What is discharge planning? It's a process involving the transition of a patient's care or a resident's care from one level to the next. The Federal Center for Medicare and Medicaid Services, CMS, has described Discharge planning as involving the following elements. Discharge planning involves determining the appropriate post-hospital discharge destination for a patient, identifying what the patient requires for a smooth and safe transition from an acute care hospital or a post-acute care facility to his or her discharge destination. It involves beginning the process of meeting the patient's identified pre- and post-discharge needs. The discharge process must be thorough, clear, comprehensive, and understood by hospital and facility staff, as well as by the patient and or the patient's representative. We will come back soon to some of the more specific federal requirements for discharge planning. But for now, let's look at some of the common discharge planning issues faced by APS. APS may get a referral concerning a person being discharged to home from a hospital or other facility who APS believes needs more care or more skilled care than can safely be provided at home. A person who APS may believe should really be discharged to or remain in assisted living or a nursing home. APS may also be involved in situations where an APS client living at home is being denied admission to home care, or a home care provider may be seeking to discharge an APS client because home care deems the client too difficult to serve. APS also may have cases in which a vulnerable person with developmental disability, a person who needs specialized supported housing, is referred to APS after a discharge from a hospital or other setting. And APS may believe that the home setting without the specialized supports for the developmentally disabled client is not safe. And in some of these cases, the problem may be that the individual has not established eligibility with the DD provider, or there may be a lack of needed resources. Or you may have the situation of a vulnerable adult who wants to return home or return to a lower than needed level of care. Or you may have a vulnerable adult whose spouse or family member wants the adult to return home when APS is concerned that the home supports are insufficient to meet the needs, address the risk, or monitor the situation of an unstable medical situation, or a situation where home services are refused by the vulnerable adult or their family, or when the home environment is in poor condition or hazardous. APS may also have cases in this situation with clients that are sometimes referred to as frequent flyers, meaning an APS client who may experience multiple unsuccessful discharges, resulting in overuse of the ER, sometimes the trashing of motels or shelters, and continued non-compliance with the resident rules. Do these situations sound familiar to you? There may well be other types of discharge-related situations that you are encountering as well, and we'll be happy to hear from you about these as we go along, and we'd be happy to see you put information about those in the chat box as well. So now let us turn to, how is the discharge planning process supposed to work? There's a reason we emphasize the words supposed to work, because, and here's a spoiler alert, you will find that unfortunately we see vulnerable persons too often being discharged from hospitals and other settings in ways that do not meet the federal or state requirements and guidance. So our purpose in going through these federal requirements and in strongly recommending that you become familiar with your additional state laws and guidance on discharge planning, our purpose is to help you to be able to recognize when the proposed discharge does not meet federal or state requirements. Being familiar with how the process is supposed to work will give you a stronger basis for assisting your clients and their families and to advocate appropriately for them. So let's start off talking about discharge planning for Medicare eligible patients in hospitals. Note that if a person is dual eligible for both Medicare and Medicaid, the Medicare discharge planning provisions should apply. A hospital is required to provide on admission a notice, an important message from Medicare, which informs hospitalized inpatient beneficiaries of their hospital discharge appeals rights. Beneficiaries who appeal a discharge decision must receive another document called Detailed Notice of Discharge. And here on this slide shows the first pages of both of these documents. I'm going to read to you a little bit from the content of these, so to give you a little bit of a flavor. The one on the left, an important message for Medicare about your rights. As a hospital inpatient, you have the right to receive Medicare-covered services. This includes medically necessary hospital services and services you may need after you are discharged if ordered by your doctor. You have a right to know about these services, who will pay for them, and where you can get them. You have a right to be involved in any decisions about your hospital stay and know who will pay for it. You have the right to report any concerns you have about the quality of care you receive to the Quality Improvement Organization, also known as the QIO, that is listed here. And they list the name and the phone number of that organization. Medicare discharge rights. During your hospital stay, the hospital staff will be working with you to prepare for your safe discharge and arrange for services you may need after you leave the hospital. When you no longer need inpatient hospital care, your doctor or the hospital staff will inform you of your planned discharge date. If you think you are being discharged too soon, you can talk to the hospital staff, your doctor, and your managed care plan, if you belong to one, about your concerns. You have the right to appeal. That is, you have a right to a review of your case by the Quality Improvement Organization. That's an outside reviewer hired by Medicare to look at your case to decide whether you're ready to leave the hospital. If you want to appeal, you must contact the QIO no later than your planned discharge date and before you leave the hospital. The form also includes information about if you want to talk to someone at the hospital about this notice, call and give the phone number. And it goes through the steps to appeal your discharge. You have to contact the QIO. Here's the contact information for the QIO. You can ask the hospital if you need help in contacting the QIO. You will receive a detailed notice from the hospital or your Medicare Advantage or other Medicare managed care plan, if you belong to one, that explains the reason they think you are ready to be discharged. The QIO will ask you for your opinion, so you and your representative need to be available to speak with them. The QIO will review your medical records and other important information about your case, and the QIO will notify you of its decision within 1 day after it receives necessary medical information. And for more information, there's a 1-800-MEDICARE number that provides information. So this is an important basic document. The other document, the detailed notice of discharge. If a patient or someone on their behalf requests an appeal, a review by the Quality Improvement Organization, this is a notice that will give detailed explanation about why the hospital, the managed care plan, in agreement with the doctor, believes that your inpatient hospital services should end on a specified date. And it cites the Medicare coverage policies. Medicare does not cover inpatient hospital services that are not medically necessary or could be safely furnished in another setting. And then the notice is supposed to contain specific information about your current medical condition, and again, some further information about how that process will work. All right, let me move here. And the federal CMS guidance, and this is sort of a summary of the statute and regulations that apply. It states that the discharge planning process includes implementing a complete, timely, and accurate discharge planning evaluation process, including identification of high-risk criteria, maintaining a complete and accurate list of appropriate community-based services, supports, and facilities where the patient can be transferred or referred, providing notification to patients that they may request a discharge planning evaluation, completion by appropriate qualified personnel of discharge planning evaluations for every patient identified by the hospital at potential risk of adverse health consequences without an adequate discharge plan, or if the patient, the patient's representative, or attending physician requests such an evaluation. Who is an appropriate qualified person to complete the discharge plan evaluation? Federal regs say a registered nurse, a social worker, or a broad category of other appropriately qualified personnel must develop or supervise the development of the evaluation. The discharge planning evaluation must be included in the client's medical record. The evaluation considers the patient's care needs immediately upon discharge and whether the needs are expected to remain constant, lessen, worsen over time. It identifies appropriate and available after acute care services, support, and facilities. The process should also offer the patient a range of realistic options to consider for acute care, depending on a pharmacist's assessment of the patient's medication compliance and treatment, the patient's capacity for self-care, or the possibility of the patient being cared for in the environment from which he or she entered the hospital. The process should also take account of the patient's preferences and goals, and also the availability, willingness, and ability of family and caregivers to provide care. The results of the, and we also, providing information to the patient's family caregivers about the post-hospital needs. They must provide information and verbal and written instruction for the patient's care. And providing, again, the notice of with regard to the availability of appeal rights. The results of the discharge planning evaluation must be discussed with the patient, the patient's representative. I also note that there are federal CMS requirements for providers to provide notice of termination and the right to an expedited appeal and for termination of Medicare paid services, not only to hospital patients, but also to residents or patients in skilled nursing facilities, nursing homes, home health care, as well as hospice setting. And further details are available under the Medicare.gov and the CMS.gov websites. What should also be noted is that even after an appeal of the termination of a Medicare or Medicaid funding for nursing home level of care, and even if the termination of the federal payment is upheld on appeal, that does not necessarily mean that the nursing home resident can be immediately evicted from the nursing home. Federal regulations require nursing home facilities to provide sufficient preparation and orientation to residents to ensure safe and orderly transfer or discharge from the facility. Residents must be provided a resident discharge summary that addresses the resident's post-discharge needs. Facilities must also develop a post-discharge plan of care developed with the participation of the resident and the resident's family that will assist the resident to adjust to the new living environment, whether it's to a private home or another level of licensed care. Right. Let's see. There is, okay, you know, this slide provides some links to some useful information on Medicare appeals rights, as well as other aspects of Medicare. After this webinar, we're going to make some changes to this PowerPoint to put a few additional citations. One of the citations that we will add or link is to a document called Your Discharge Planning Checklist for patients and their caregivers preparing to leave a hospital, nursing home, or other care setting. To provide good guide for the layperson as to the specific things that patients and their helpers should focus on in terms of post-discharge planning. For example, where will you get care and how will it be provided? What are your options? What are the health problems you currently have and what can you do to get better? What tests will you need and who can you call if you have questions? Will you need any medical equipment and how will this be arranged for? What, if any, help will you need to do activities of daily living? What supports will you have once you are discharged? So this is a booklet that tells patients and their families and representatives that it is important that they ask for discharge planning instruction that they can understand. And it's a booklet that provides a helpful checklist to remind patients and their helpers to ask the right questions. And it also provides a concise summary of discharge appeal rights. And I'll make sure that the PowerPoint that goes up on the NAPSA website following this also has a citation to that helpful guidebook. And I think we'll also put on some additional citations to the federal regulations about discharge planning and discharge rights for nursing homes and home health aid patients as well. I also want to let you know that if you go to the NAPSA website, the opening page, you'll find the guidance on discharge planning that this webinar is based on. So go to www.napsa-now.org, the opening page under the heading What's New with NAPSA. You'll also find there a number of the documents, links to a number of the documents that are referenced here. So this slide cites the federal statute and regulations setting forth requirements for hospital discharge planning. We've given a brief overview of some of the federal statutes and regulations and guidance regarding discharge planning. But it's very important for APS to know whether there are additional laws or policies governing discharge in your own state. I mean, these could include, for example, as we say, required procedures for hospitals or nursing homes or home care to follow regarding rights to participate in discharge planning, resident patient appeals rights, and what documentation the provider has to issue to the patient or residents, and what documentation that needs to be maintained in the case record. In New York, for example, state law requires that hospitals, nursing homes, and home care provide discharge-related rights to any patient or resident, no matter what their source of payment. Well, thank you for listening to me up to this point, and now I'm very happy to have my colleague Deb Greenfield talk to you about some of the best practices we are aware of to help APS and its partners assist clients in this area. Deb, take it away.
Okay. Just real quickly, if I may, this is Lori. We did get a question about whether the PowerPoint would be available later or whether people need to keep writing furiously. So we do want to let you know that we will be able to make the PowerPoint available through NAPSA at the end. Or not immediately, but we will get it to you. Thanks. Deb, sorry. Go ahead.
That's okay. No problem. In New York State, we've done a lot of work over the last several years in trying to improve the discharge planning experience. First of all, a suggestion is that you know the rules regarding discharge planning and appeals, so you can be in a position to provide support to clients and their families and representatives where appropriate, which is easily said. But when we are talking about discharge planning, and we're not just talking about hospitals, we're talking about every level of care. So it could be from a hospital or a nursing home, an assisted living program, home care, a variety of different settings. Now, in what we've done is we have made connections with the people in the sister state agency, in our case, the Department of Health, that oversee these various levels of care. Everybody has rules regarding notice of discharge and due process, but they're all going to vary to some extent, and it's difficult to be well-versed in every single one. So when these questions come up on a state level, we have somebody to call if we have questions or concerns. And that's been extremely helpful in trying to navigate these processes. Also, we believe that you should consider an issuance of written guidance to adult protective services shared with hospitals and the facilities, stating that discharge to APS in the absence of other necessary services does not constitute an acceptable discharge plan. It's probably not uncommon for many of the adult protective units out there to have those discharge to your front lobby types of events that happen. And that's obviously not what we consider in a state an appropriate discharge plan. How do I change? Okay, suggested best practices continued. Just so you're aware, patients that are in observation status, even if they've been in the hospital overnight, even if maybe they've been in the hospital for a couple of days, are not considered admitted patients or inpatients for the purposes of many things, including financial billing, but also in terms of discharge planning. So the same rules that the hospital has to follow for discharge planning from an admission do not extend to people who are in observation status. So it's always helpful to ask, because you may not know. Somebody who's in observation status may be in a bed right next to somebody who's been admitted. So it's a good thing to ask so you know what you're dealing with. Also, patients that are only seen in the emergency room and are not admitted as inpatients. Again, the hospital does not have to follow the same discharge rules as they would for a hospital admission. Hold on 1 second. There we go. Things to consider when a hospital or facility refers a patient or resident to APS. A hospital or the facility has to provide information to APS, which leads APS to conclude that the client will be returning to the community upon discharge and that the client may be eligible for APS upon such return to the community. To determine this, APS needs to receive all the pertinent information regarding the patient's medical, cognitive, and social condition in order to make an assessment that whether or not they do qualify for adult protective services. To do this, adult protective has to be engaged during this process. Occasionally we run into a response where a hospital or a discharging facility may call APS and say, we're planning discharge for this person in a couple of days, a week, or whatever, and they receive the answer that, well, currently this person is being cared for in a safe environment, therefore we're not accepting the referral. Probably not very helpful. It's important, whether APS technically opens a case or acts in a consulting capacity. It is important to get in, to talk to the hospital, to find out what the circumstances are so that you're prepared if that person is appropriate and does become an APS referral. You know what's happening, you know how to plan, and you avoid those last-minute crises. So we strongly recommend that when you get those kind of calls, that you engage with the discharging entity in some form or fashion. Something here. Hold on. Suggested APS best practices again. An APS assessment of a patient in a hospital facility should be conducted in close cooperation with discharge planning staff. The APS assessment will place special emphasis on the client's physical environment and the degree to which the client's support system will be able to meet clients' needs upon discharge. Typically, if the person who's in the hospital already is an APS client, APS has a really good handle on those kind of things that will be facing the patient when the patient returns home. If it's a new patient, it may require someone to take a look and do an assessment of what's waiting for them on a return home and whether a return home under those circumstances is going to be appropriate or not. Even though APS may conduct an assessment and they have some degree of involvement, that does not diminish the hospital or the facility's primary responsibility for discharge planning as set forth in federal and state laws. The hospital and facility retains responsibility for accessing all the necessary post-hospital and facility services, such as personal and home health services, prior to the discharge. APS does not accept primary case management responsibility for the patient resident until discharge and return to the community. Remember, patients, residents have a right to self-determination in choosing or agreeing to a discharge plan. A person who insists on returning to a dangerous home environment upon discharge is free to do so unless it is determined that that person lacks capacity to make and understand decisions related to his or her care. And we all know that those are some of the most difficult cases that we have to deal with. However, the fact that APS is involved in those particular cases and provides some kind of ongoing support and an eyes-on type of check to make sure that the person is doing as well and minimizing what risk is out there for that person is very important. If capacity is in question, APS should seek a psychiatric evaluation before the person is discharged, focusing on the ability to make and express choices about decisions, ability to provide reasons for these choices, ability to make choices based in reality, and ability to understand, appreciate the potentially harmful consequences of his or her action. If the determination is made that the patient resident is not presently able to make care-related decisions, and that patient resident will be at risk of harm upon discharge, then the hospital must act to prevent or delay the discharge in accordance with law. So that might involve a period of time of correcting issues that may be dangerous for that person at home, whether it's heavy-duty house cleaning or making sure that there are sufficient support systems there. That's one option. Another thing we often see is guardianship requests. If determination is made that the patient resident does have the decision-making capacity, the hospital, facility, and APS have no choice but to allow that person to return to the community. It's good practice to enter into agreements with hospitals and facilities, setting forth respective roles and responsibilities of APS and hospital facilities for persons facing discharge. Some states have provided APS with those models of such agreements, and New York State does have such a model, which was developed both with the input of OCFS and the Department of Health, and strongly recommended that APS share that with their local hospitals. It has been helpful in determining who's responsible for what and when. It also, in our state, answers the question, which is a frequent question, of who's responsible for pursuing guardianship. So in New York, if the person has been an APS placement prior to the, or APS client, prior to the hospitalization, then APS takes on that responsibility. If not, then the hospital would take the responsibility of requesting guardianship, and then, of course, the assignment of a guardianship is up to the judge. Some APS units, for example, New York City APS, have developed standard letters to send to hospitals or facilities in cases where APS clients receive notification that they will soon be discharged, and where APS believes that the discharge would not be safe and would not conform to applicable law. In appropriate cases, APS sends the letter to the hospital facility requesting discharge be postponed until such time necessary services are reasonably available. It also cites the applicable discharge regulations in New York State. And that is very helpful because if nothing else, it starts a paper trail, which is beneficial. Nobody can say that they didn't receive the phone call or didn't get the message. So a written notice can certainly gain some attention. And I think it has been a helpful method in a number of different cases. And those letters have also been used in other counties of New York State with good results. The letters that also list the services that APS thinks is necessary to meet continuing health needs and states that these services had not yet been made available. It also states that discharge to APS in the absence of other necessary services does not constitute an acceptable discharge plan. APS is opposed to discharging the patient resident at this time, and until such time as the service is necessary to ensure a safe discharge plan are available. So that puts the hospital on notice. And on your screen in this slide, this is an example of the New York City hospital discharge letter. And also next is the notice of unsafe nursing home discharge. You are welcome to use to your benefit. Those sample New York City letters can be found at the link on NAPSA under sample discharge letters. So they're available to anybody who would like to use them. Patients or someone on their behalf need to communicate to the hospital and facility what resources actually have at home. The housing, what are the transportation needs, what assistance is going to be needed with the activities of daily living, and what social supports are available. It is extremely important that patients or someone on their behalf communicate with the physicians, nurses, and discharge staff about concerns about inappropriate discharge. In New York State, several years ago, a discharge planning work group was convened. This was an outgrowth of a most integrated setting group on a state level that recognized between state agencies that discharge planning was a major concern in this state, and that there were a lot of difficulties surrounding these types of transitions from one level of care to the other. This group brought together people from a variety of state agencies, including OCS, DOH, who oversees in our state at least all those levels of care that we've been talking about, and a number of direct providers, be they nursing home providers or hospital discharge planners, home care providers, adult protective units, and several other local, public, and private people, as well as consumer advocates. And everyone participated in this work group. And it was exceptionally helpful, both because it educated all of us about the concerns and the rules of the other players in the game. For example, we all know, I'm sure, that hospitals are not necessarily the best place for people to be more or less held when they no longer need acute care. However, in the systems that we have, sometimes it's the only option that we have available. And we're sensitive to the fact that hospitals have issues about funding and infection control and things like that make them concerned about keeping people beyond what is considered to be their discharge date. So it was very helpful to be able to hear what their concerns were on many local levels. We had included counties and providers so that they could meet together and share their concerns and work as a collaborative team to help in these transitions. I know Albany County, for example, would meet frequently, not on just crisis cases, but on an ongoing basis with the 3 major hospitals in our area to develop means of communicating and planning for people that were going to be more of the complex discharge planners. The group also developed tools for discharge planners and consumers addressing safety, discharge planning education, and consumer education. So this grew out as essentially as a statewide basis, but also worked itself down to a more local or regional level. It's important to have those relationships with the providers in your community so that you're not seen as adversaries, so you understand each other's limits and concerns and are able to work out the best way of meeting the patient's needs. Safety concerns that impact an individual wishing to live in the community and key elements for effective safe discharge planning to facilities and individual rights to choose are a couple of the resources that are available on the DOH website at the link below that talk about some of the methods that the discharge planning work group worked on to try and bring all these pieces together in one place for everyone that was involved. And those are accessible to anyone on that website. There's also a piece on what the discharge planner needs to know in order to effect a safe and efficient transition. What consumers and their families need to know before being discharged to home care, what consumers need to know about their abilities and responsibilities. As part of this work group also, as time went on, we also developed what was called a complex case work group. And what would happen with that is that a hospital discharge planner anywhere within the state would contact a representative of that team with details on a case that was problematic for the hospital. Once they did that and provided the information, a group representing all of the various areas would do a conference call with that hospital and attempt to brainstorm solutions. That at one point was occurring on a regular level. Sometimes the solutions were not easy to find. It's not a perfect world, of course, in all those areas, but it was helpful to have input from the various groups and providers out in that area. But I think the biggest thing that came out of the discharge planning work group was relationships and communication. It's extremely difficult to know all the rules and regulations for every single level of care out there. I'm sure it must vary to some degree state to state, and it is helpful if you have somebody you know to talk to who understands that your best interests and their best interests are served by that collaboration.
And this is Alan. I think in many respects it's similar to the relationships that you will build with a multidisciplinary team in doing APS investigations. You're building trust. You're learning what the system can do and what it can't do, who to contact, and working together you build trust.
And it's an ongoing issue. I know many of our APS units do regular presentations to discharge planners in hospitals because there is that turnover that's inevitable. And oftentimes they have to go in and repeat and meet new people and develop new relationships. I'm sure it's not a surprise to anyone out there that there is often a misunderstanding of what APS can and cannot do out in the community. So those types of outreach efforts are extremely important and very helpful.
One thing we haven't touched on, I don't know if you want to say anything, Deb, about sometimes there are persons who are coming out of jail.
Yes, that does happen also. And actually in the statewide work group at that point, we had representatives of parole and Department of Corrections. Department of Corrections often had people coming out of prison that needed some kind of medical care, often nursing home care. And as you can imagine, there is certainly some stigma to caring for these people. So it was helpful within the planning group to share resources. In some cases, there were certain, for example, nursing homes that would be willing to work in conjunction with the parole officer to provide sufficient supervision, to deal with people who may have certain behavioral concerns and take them on, as well as certain home care agencies that may be more willing than others to accept that kind of case. So the communication to be able to have those resources accessible was very helpful.
And we have seen some instances in which APS throughout the state have, knowing what a discharge plan should be and feeling that in certain cases a vulnerable adult was going to be discharged to an unsafe situation, did push back. Certainly New York City, using these letters that we are referring to in other parts of the state as well, pushing back. And in the guidance, we have talked to APS, local APS, advised APS to act as advocates or support the families in being advocates and others, and to take measures to initiate appeals processes when that's appropriate. In some cases, too, if there is actually going to be an inappropriate or there has been an inappropriate discharge, to contact the complaint lines for the New York State Department of Health.
Yes, and in our state, they do follow through on those complaints when they're received. And
similarly, on the we have been able to reach out when we've heard from county APS, and in our state it's county administered, state overseen. When we've heard the situations of inappropriate discharges by local hospitals or other settings, we've been able, in the past, to reach out to our partners, our state partners at the Department of Health that regulates those facilities, and they have intervened and been of assistance on occasion. But as Deb was saying, the relationship is just really important.
Crucial, because there have been many circumstances where we would call the home care director for New York State Department of Health, and they would intercede on a local level just to make sure that their agencies were following everything they needed to do, or helping us create a dialogue between the local APS and the local home care agency. So where we could intervene, where we might be able to put in a house cleaning type of service, or do help with an order of protection for someone who was interfering with care, those kind of interventions could be done.
Right. Lori, have there been any questions that we should be responding to?
Yes, we got one question asking what laws are they supposed to be in accordance with? So can we put back up the federal, the link to the federal
yes,
federal law?
I want to do some
Flipping.
Yeah, no, I know you've got to do some flipping.
I want to flipping. Okay.
I did tell them, if I understand this correctly, that there may also be state regulations that people need to be looking for. How would they search for those?
Okay. Well, I think the best way to you should be talking to people, it's best person to person, talking to people in the other state systems. Whether, in every state there's generally one major state agency that's responsible for long-term care, though it may be different in your state. And whether you reach out to those people, have a discussion, whether you go to their websites, and because often you can find a heading of discharge planning. But I think it's really important to have that dialogue. So about this slide, these are the federal statute and regs relating to hospital discharge planning for Medicare beneficiaries. What we are going to do before we put this PowerPoint on, we're going to add some additional information and also give you citations to federal statute and regulations relating to nursing homes and home health agencies as well. There's some federal guidance on that. And the guidebook that I mentioned, the handbook with a checklist, also is a very useful information for patients or residents and their families in thinking about the important discharge questions to be raised and addressed, not just for nursing homes, but also hospitals and home care as well.
Also, I just want to mention that in New York, we have regional meetings for our adult protective supervisors, and on a number of occasions, we've been able to arrange for someone from the appropriate state oversight agency, whether it's Department of Health or Office of Mental Health or Office of People with Developmental Disabilities, to come out to our regional meetings and speak directly to our adult protective supervisors about various issues about discharge planning and service availability in their communities.
That it would be helpful. We do have another question. We frequently come in contact with nursing facilities who contact APS regarding non-payment and want to discharge them due to this issue. Does this fall under the issues of discharge planning?
Well, there's a distinction between non-payment. Non-payment is the basis for terminating a nursing home placement. However, you can't just throw someone out after, you can't throw someone out while they're appealing or until there's a safe alternative for them to be living at. And there are federal regs and there are state, I'm sure there are state regulations, as there is certainly in New York, guiding nursing home residents to protect them, and seeking to involve nursing homes residents and their advocates and families in terms of understanding their rights. And beyond, and sometimes the local office for the ombudsman can also be of assistance in conveying discharge planning information. But certainly, if someone is private pay and they exhaust their private pay and they're eligible for Medicaid and they are applying for Medicaid, the federal laws say you can't throw someone out while there's a pending Medicaid application pending, for example. So yes, I mean, non-payment is is a basis for termination after appeals rights have been exhausted, but there's also the requirement for nursing homes to plan carefully in terms of what the needs are, the post-discharge needs will be, and make sure that there's a process that's been followed. And there are the citations that we will include in the revised PowerPoint will also provide citations to the workups, you know, in terms of discharge planning workups that need to be in the nursing home case record and given to the nursing home resident and their representatives to protect them and make sure that the discharge is safe.
And they
All
have
right.
hearings.
We have hearings. The other thing I just want to mention, throw out, in one of our regional representative meetings, I seem to recall someone from, and I don't recall what state it was, saying that they viewed unsafe discharges as being a form of elder abuse, to the extent that that state was actually citing the nursing homes for in terms of adult abuse. If someone is listening who is, you know, a representative of that state and can provide us some additional information about that, that's sort of an aggressive approach that some of us you know, like, but and it'd be interesting to hear how well that has done, and it'd be interesting to hear from others in other jurisdictions about their attempts to push back on unsafe discharges and what has worked, because we want to share the best practices that are available and help everybody in what's a challenging environment. And we recognize it's challenging for the hospitals and the nursing homes as well, because in some state cases they're being pressed by the federal government and in order to make sure that only medically appropriate people are in the hospitals, and or citing hospitals sometimes when people come back too soon. So though I guess you can kind of use that counter argument and say, well, you don't want to be cited for someone who shouldn't have gone out in the first place because they still have the medical needs going out, and then they'll have to come back, and then you the hospital will be cited by and money taken from the federal government. So
yeah, it is a complex problem. We have reached the top of the hour. We did have a couple other comments that were in there, but I think they were addressed by the actual PowerPoint. So when we have the PowerPoint to send out, I think you will get those answers pretty clearly. They're about what happens if someone's not actually admitted, they're in the ER. We've answered those kinds of questions, I think. Thank you both for being willing to be on this call today. This has been, you've done a wonderful job of explaining a very complex issue and how you're addressing it, and where there are some actual ways to address the issue. We totally appreciate that, but we need to let everybody go because we're at the top of the hour. Thank you, and thank you all from NAPS as well for participating in the webinar.
Thank you.
Thank you. Ta-da.